How are we doing? Are we good? Do we need more time? Will you give me a hand raise if you need more time? We think we're good? Okay. All right. We'll try the volunteer route. So case one, does a group want to give me their thoughts on case one? What's the harm? What's the preventability? What's the culpability? Case one. Who got case one? Yep. Go for it.
Oh, I don't need to answer it. That's somebody else.
Fair enough.
Okay.
So we decided that it would be a mild harm because
Hang on one sec. Hang on one sec. Here you go. No, you don't need to read the case.
So we decided that it would be mild harm because it did cause like an extended stay in the hospital, but it didn't have any long-term effects on the patient. It was a preventable error because she did deviate from protocol, and it was a system-induced violation. Do I need to go through that, or?
No, you don't. have to.
Okay.
Okay, so wait one more time. So we had mild harm, okay, was preventable, okay, and system-induced violation. So somewhat culpable, okay. All right. Anybody that had that case think differently? How do we feel about the harm? Let's go back to that. So this is where it gets a little washy, right? So that's very good, by the way. Thank you. So whenever we go to the harm, so we have mild harm. That was fast. Brought batteries, huh? All right. So thank you, sir. I can replace it if you want to leave them there. Mild harm. So we see an increased length of stay. Bodily or physical injury. Thank you, sir. Bodily or physical injury adversely affecting functionability or quality of life. What do y'all think? Mild, moderate, still like mild? How many think mild? Yeah, I'd say mild. You could maybe make an argument for moderate, but I think it's probably mild. Depends on what happens after that surgical site infection. If there's no further complications and she goes along with life and no big deal, then, shame on us by all means, but at least it wasn't any type of permanent harm. Okay, who should foot the bill for that extended length of stay? Hospital? Yeah, I kind of agree with that too. All right, let's go to the second case. Who had the second one? Give me a hand raise, and I'll come to you. Second case? Second case? Second case. Oh, goodness. All right, thank you. I was about to start going down TBL numbers.
For the second case, we said it was mild harm. It was a preventable error and a possible negligent error due to the lack of following the policy of screening the patient.
All right, let's go back to that. So you said, let me make sure we captured that right. So you said mild harm, okay, was preventable. What was the last part? Negligent error. Okay, mild harm. So it doesn't look like the patient got hurt, though. Why did you say mild harm? We had to monitor. We drew extra labs for serum creatinine. Perfect. Great. The big difference between this case 1 and case 2, though, but they're both considered as mild harm, which is kind of interesting. Let's go back to, and preventable, I absolutely agree. But let's take a look at this. So they deviated, but let's go through this kind of thing. So some people would argue, which one did you say again? Sorry. Possible negligent error. Yeah, actually, no, that's spot on. Good. Yeah, so we went with possible negligent error because if you look at this whole process, so past substitution test, some people would actually say you could go down this route and say yes, right? Go down the far right. Depends on who you put in that substitution test. So you can say any hospital CT radiology technologist, or you could say a brand new radiology CT technologist. You could argue either one, honestly. A lot of people would put this in the blameless error category and say we need better processes because that person should have known. That person should have been trained. They should have been demonstrated as competent in all of their training competencies before getting here. So it kind of depends. Had they finished their training? Had they not? I think that's actually really good. Possible negligent error. They just kind of missed it. Yes, sir. Correct. Yeah, correct. No, you're absolutely right. And so what I'd say is, all three of these cases are real, by the way. These aren't made up cases. So the first one, very much just one of those things that, we deviate sometimes, then you have that. The second one, we actually changed the system. So we changed the system on this one. So what we did was, this actually made it to where we sent the radiology orders, the CT radiology tech had to input the order. They actually started inputting the order. We had to give them provider credentialing so that they could input the order into the health record, and it would go to the pharmacist to verify. So it gave them an extra layer of capture. So that way we could kind of prevent those types of errors from happening. Good. Case 3. Yes, sir. Coming to you. Great job, by the way, guys.
So for case 3, we concluded that the scale of harm was death, because since the patient died. It was preventable, and the culpability was system-induced violation.
You agree? You concur? I do concur. All right. So make sure we capture that. So, yeah.
If you follow that chart, the log chart, it will lead you to system induced. But I can argue that it was also reckless because the charge nurse did not do the job, just said that, hey, here's my credential, sign it off.
Yeah.
Isn't that reckless? Not system induced.
It's very interesting. So this one gets a little stickier, right?
It's not intended because of what she didn't intend for that harm to happen, but it did cause due to her reckless behavior.
Right. So you make a really good point. It is due to it. Was the nurse being reckless, or was she a product of her environment? And that's the argument that you make, right? Like, that depends on how you're looking at this, and as you're doing a root cause analysis, that's the question you want to answer. Was she influenced by a culture of unsafety, for lack of a better way to put that, or was that a deviation? Yes, ma'am. Yeah, it's a two-way street, right? So basically, whenever somebody sits there and says, hey, can I have your credentials to sign on, and they just sign on, you've just contributed to the problem. Both these nurses no longer practice nursing anymore, if you were wondering. This is, and actually the nursing manager, if I recall, actually got fired and was also implicated in the lawsuit because it was kind of a blend. You had a culture of unsafety, but does that really excuse the behavior, right? It's up to you as a professional to stand up and say, that's not right. It's easy, but it's not right. There's a reason these types of things are put in place. So it's always important before you, for lack of a better way, subvert a workaround or create a workaround or subvert the process. It's important to ask, why is that process there? Okay. And this particular process would have saved this young lady's life. Questions about this? Good? Helpful? Helpful in understanding the concepts? Good. Okay. Let's talk about the case we already talked about. Let's talk about the one we opened the day with and, that we're going to, I guess, eat ourselves into a happy mood in a minute with. But let's talk about that case. What about that case? How about the harm? That one's pretty easy. Death. I mean, you could argue that the initial event was before then and it was severe harm and that it evolved to die, to the patient dying. What about the preventability? Yeah, it seems preventable, right? Not knowing what the procedures are for the facility, and you have to dig all that stuff up. You have to really dive in and figure out what the deal is, but it seems very preventable. First off, they were administering drug too fast, too soon. Okay. What else was preventable in y'all's mind? What other deviations happened in that first case? Yes, ma'am. The entire team wasn't ACLS certified in an environment where a code could easily happen, where dangerous drugs are administered. I'd agree that's a deviation. Good. What else was a deviation that y'all recall? poor documentation. That's a deviation, right? That's a core tenet. If y'all didn't know that in healthcare, that is a core tenet. The phrase is oversaid, I'll agree, but it's never doesn't make it less true. If it didn't get documented, it didn't happen, right? Okay. Do we document for each other? Why don't we document for each other? Hey, you're busy, I'm busy. I'm running this code, and I don't remember everything that happened, or I remember everything that happened, but can you document it for me? Why don't we do that? It's unreliable, right? What other deviations happened here? What other deviations do you recall? Yeah, the dosing. Yeah, dosing of the medications. So appropriate dosing of medications. Okay. Did it tell you who was administering the conscious sedation? Who was the nurse? 25 years experience. Didn't tell you what kind of experience though, did I? Medical surgical. But she says she has done conscious sedation numerous times before. Who do y'all think probably does conscious sedation most of the time? Yeah, anesthesiologist or a nursing anesthetist. Wow, that is really hard for me to say. Who might, would it be okay for a nurse to administer conscious sedation, do you think? I mean, I know y'all haven't been practicing or anything, but yeah.
If the nurses IR trained, then they sedate all the time.
Yeah, absolutely. If the nurse is IR trained, they're experienced in doing it, they keep up certification, they keep up training, they maintain their CE, they do all those types of things, then heck yeah, they can do it. They're fully qualified to do it. Okay? Based on the information that I gave you, did it seem like this nurse was aware of how the drugs worked or how fast they worked or what the consequences were?
She sure spoke up.
Probably. It's a good point. Okay? Any other deviations? What other deviations do y'all recall from the case? What's that again? That's not necessarily a deviation. It does make you ask the question, though. Do you think that a patient should get the same level and quality of care at a standalone radiology versus a radiology in a hospital setting? Should they receive the same level of care? Maybe different people, maybe a different team, but yeah, I mean, the idea is, that they should be able to receive that same level of care elsewhere. Yes, ma'am.
Were there only two people, medical team members there? Is that how you?
There were two technologists. So there was the physician, the interventional radiologist. There was a nurse that was acting as the anesthesia provider, and then there was and monitoring the patient, and then there were two technologists assisting with the procedure.
Is that like good enough standard-wise in terms of the procedure?
I think we have a pseudo expert in the room. What do you think?
That's like normal for IRC. One runs the IRC, and the other one runs and gets the items.
Yeah. Yeah, 14 members is pretty routine. So, yeah. No pharmacist to verify meds, and that's actually fairly normal too. Usually these standalone ER, standalone radiology suites, they don't have those, and so that's why it's so important they stay up to date on the meds and how they work and how they're administered and all those types of things. Any other deviations? This is a great discussion.
Take into account any of the patients, like you said, she was on amitriptyline for depression. Did they take that?
Yeah. So processes, procedures.